Good evening. We will speak today about COPD, which is chronic obstructive pulmonary disease. Our lecture outline will be about a small introduction, the types of COPD, the pathophysiology behind it, the risk factors that can cause it, how to diagnose COPD, the management, the complications of COPD, and COPD and asthma overlap syndrome. The introduction: COPD affects more than 5% of the population and it is associated with high morbidity and mortality. It is the third ranked cause of death in the United States, killing more than 120,000 individuals each year. 50% of COPD population are not diagnosed, and 30 to 70% of the diagnosed patients are managed suboptimally, unfortunately. The burden of COPD is projected to an increase in coming decades due to the continued exposure to the risk factors and due to the aging of the world's population. It is associated with a significant economic burden. The definition of COPD, I think we know it. It is a common, preventable, and treatable disease. It is characterized by persistent airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. So it is important to remember that it is a progressive disease, it has chronic inflammatory response, it is irreversible narrowing of the airways or damaged airways. It has two types. It has chronic bronchitis and the emphysema. The chronic bronchitis is defined as chronic productive cough for 3 months in each of 2 successive years in a patient in whom other causes of chronic cough have been excluded. In the emphysema part, it is an abnormal and permanent enlargement in the air spaces distal to the terminal bronchioles that is accompanied by destruction of the air space wall without obvious fibrosis. We'll speak a little bit about the pathophysiology behind the COPD. There is changes in the airway and there is changes in the alveoli occurs. The changes in the airway, there is chronic inflammation. The chronic inflammation will cause narrowing of the airway and release of the inflammatory cytokines that will affect the elastin and the recoil properties of the lung. في عنا increase in the number of the goblet cells and mucus gland hyperplasia that will lead to mucus production. We will have fibrosis, so we have irreversible inflammation and narrowing of the airways. في عنا narrowing and reduction in the number of the small airways, and we have airway collapse. Why do we have airway collapse? It is due to the loss of the tethering protein elastin due to the production of proteases by cytokines from chronic inflammatory response, which will lead to loss of the elastic recoil of the lung tissue. In the lung parenchyma, or how the lung parenchyma is affected, it is affected in emphysema mostly. Emphysema affects the structures distal to the terminal bronchiole, consisting of the respiratory bronchiole, alveolar ducts, and alveolar sacs, and the alveoli, which is known collectively as the sinus. It will cause destruction of the walls of the alveoli and decreasing the diffusing surface of the lung. We have multiple risk factors that can predispose to COPD, which one of the most important risk factors is aging population. The aging population is a very important risk factor. The second most important risk factor is cigarette smoking. Other risk factors are like occupational dust and chemical exposure, environmental tobacco exposure, passive smoking, indoor and outdoor pollution, genetics, infections, and socio-economic status. The lower the socio-economic status, the more we have COPD patients, not like asthma. About genetics, Genetics, it is known that for a father with a COPD, it is more common for the sons to have COPD. It is heterogeneous, non-specific, and we don't have certain genes to certify that those patients will have COPD. The other part of genetics, we have like alpha-1 antitrypsin deficiency. It's a genetic condition that is responsible for about 2% of cases of COPD. In this condition, the body does not make enough of protein alpha-1 antitrypsin. The alpha-1 antitrypsin protects the lung from the damage caused by proteases enzymes such as elastase and trypsin that can be released as a result of inappropriate inflammatory response to tobacco smoke. Symptoms of COPD. In symptoms of COPD, we have the characteristic symptoms of COPD, which is chronic and progressive dyspnea, cough, and sputum production that can be variable from day to day. Dyspnea, it is progressive, persistent, and characteristically worse with exercise. In chronic cough, it may be intermittent and may be unproductive. Chronic sputum production, COPD patients commonly cough up sputum. The change of the amount, color of sputum will indicate exacerbation. Other clinical features that can be found in COPD patient: wheezing, chest tightness, weight loss, and respiratory infections. To evaluate the symptoms of COPD patients, we have two scoring systems, the MMRC and the CAT. The MMRC, it is a modified medical research council questionnaire, which is a dyspnea scale. It has grades from 0 to 4 to assess breathlessness. The grade 0, he only get breathless with strenuous exercise. 2, 4, which he is too breathless to leave the house, or breathless during dressing. Those two scoring systems are important in the treatment of COPD, which is included in the GOLD criteria. How to diagnose a patient with COPD? At first, we only diagnose patient with COPD if he is having symptoms. So we investigate patients to have COPD or not having COPD only when he have symptoms, when he have dyspnea, as we said before, chronic cough, or sputum production. Without symptoms, we don't go and screen the general population. The golden standard for diagnosing COPD is spirometry. What do we find in spirometry? We find that the FEV1 على FVC ratio is less than 70%. That confirms the presence of persistent airflow limitation. Only diagnosed post-bronchodilator. Why? Because it is irreversible, as we said. If it is reversible, it has a question mark to have asthma. Okay, this slide is an important slide. It is a guideline for management in COPD. At first, we should diagnose the COPD patient, as we said, spirometrically, confirm diagnosis, which have an FEV1 على FVC less than 70%. Then we will grade our patients with the GOLD criteria from GOLD 1, 2, 3, and 4 according to the percentage of reduction in the FEV1. So if FEV1 is more than 80%, it's GOLD 1, GOLD 2 we have 50% to 80%, GOLD 3 is 30% to 50%, and GOLD 4 is less than 30% the FEV1 of the predicted. It is important also to know that GOLD 1, 2, 3, and 4 is not enough for the treatment guidelines in COPD. It is important to incorporate the number of comorbidities, the number of exacerbations in the past year of the COPD patient, and the symptom scales that we talked about, the MMRC and the CAT criteria, to make our patients in groups, Group A, Group B, Group C, and Group D, according to the exacerbations and the symptoms. To continue on the diagnosis of COPD, we will do a blood examination. Blood examination will help us in two things. In acute exacerbation, it will show if the patient has leukocytosis that can lead us that the infection is a cause. The other thing, patients can have polycythemia. Polycythemia is increased hemoglobin above normal levels, with a female more than 16.5 gram per deciliter hemoglobin and the male more than 18.5 gram per deciliter hemoglobin. It is secondary cause of polycythemia due to chronic hypoxia. We can examine sputum examination by gram stain and culture to look for infectious causes such as strep pneumonia, Haemophilus influenza, Moraxella catarrhalis, and Klebsiella pneumonia. We can do arterial blood gases in the hospital to see if there is hypercapnic respiratory failure or hypoxic respiratory failure. About the management, it is based on principles of the prevention of further progress of the disease, preservation and enhancement of the pulmonary function capacity, avoidance of exacerbation in order to improve the quality of life, which is very important. In management of COPD, we divide our drugs into categories. The first category is bronchodilators. The bronchodilators are central to symptomatic management of COPD. It improves the emptying of the lung, reduce the dynamic hyperinflation, and improve the performance. The bronchodilators are divided into long-acting bronchodilators and short-acting bronchodilators, and it is divided also according to the mechanism of action to beta-2 agonist and to antimuscarinic receptors. في عنا three major classes of bronchodilators: the beta-2 agonists, short-acting salbutamol and terbutaline, the long-acting such as salmeterol and formoterol. The anticholinergic or antimuscarinic agents are the ipratropium and tiotropium, and we have a third bronchodilators which is thiophyllin. It is a weak bronchodilator and has an anti-inflammatory effect. It is not used frequently in patients with COPD due to the narrow therapeutic range of the thiophyllin. Glucocorticoids. Are glucocorticoids used in the management of the COPD? Yes, it is used. It is used in category D, which we talked about in a previous slide, in those patients who have a higher level of symptoms and a higher level of exacerbation or higher number of exacerbations. Glucocorticoids are not used alone in stable disease treatment. It is used in combination with inhaled bronchodilators. In acute exacerbation, it is used to relieve the acute exacerbation. Chronic treatment with systemic glucocorticoids should be avoided because of the unfavorable benefit to risk ratio. We have another category of drugs that can be used in COPD patients, which is the phosphodiesterase 4 inhibitors. Another name of it is roflumilast. It has an anti-inflammatory properties. It is only used in a very specific and narrow category of patients which has only chronic bronchitis. It is not effective in the emphysema patients, and it is an expensive disease. We have a combination therapy of long-acting beta-agonist and inhaled corticosteroid that showed a significant additional effect on pulmonary function and the reduction of symptoms. We used it only in category D, which we talked about previously. Mucolytics, we can use mucolytics. It is beneficial. As an example, we have an N-acetylcysteine. It is beneficial, as we said. It has an anti-inflammatory effect, and most importantly, it decreases the viscosity of the sputum. Antibiotic use is limited in COPD for the acute exacerbation. There were studies to use macrolides as azithromycin chronically because of its anti-inflammatory effect, but the studies showed that it only increases the resistance for the macrolides, so it was dropped out. Other pharmacological treatment, it is important to cover our patients, our COPD patients, to prevent exacerbation. So it is important to give them vaccines. The vaccines that should be given is an annual influenza vaccine. The pneumococcal polysaccharide vaccine is recommended for COPD patients, those more than 65 years, and COPD patients younger than 65 with an FEV1 less than 40 of predicted. The oxygen therapy is one of the very important management in COPD treatment. It prolongs survival when used long-term autotherapy. It improves exercise, it improves sleep, cognitive performance in patients with respiratory failure. The therapeutic goal is to maintain the oxygen saturation more than 90%, and the partial arterial pressure of oxygen more than 60 millimeter mercury at sea level and at rest. There is certain indications for long-term oxygen therapy. We recommend testing with an ABG for patients with COPD when the FEV1 is less than 35% of predicted, when our patient is having a saturation less than 88%, or an a partial arterial pressure of oxygen less than 55 millimeter mercury. It is important to emphasize that the patient should continue for at least 15 hours a day on the oxygen to have the benefit from it. How do we test for patients eligible for long-term autotherapy? He should have a stable disease for at least 3 weeks, and we should repeat the ABG twice over 3 weeks to confirm the need for oxygen, regardless if he is a CO2 retainer or not. Other indications are when the partial oxygen pressure is less than 60 with pulmonary arterial hypertension, or right-sided heart failure with lower limb edema, or if the patient is having polycythemia. Other treatments used in COPD, something called pulmonary rehabilitation. What is pulmonary rehabilitation? It is used in acute exacerbation, and it keeps going on after the acute exacerbation goes away. It is basically an exercise program to decrease the feeling of distress and dyspnea, to improve the lifestyle of the patient, and to improve the perception of symptoms. It is important to monitor the nutrition of our patient. The other treatment that can we use is surgery. Surgery is recommended in certain patients in COPD. في عنا multiple types of surgeries such as bullectomy, lung volume reduction surgery, and lung transplant. The surgery prolongs survival also. One of other treatments that can improve survival in our patients, and one of the most important behavioral changes for COPD patients, is smoking cessation. It has the greatest capacity to influence the natural history of COPD. The pharmacotherapy and nicotine replacement reliably increase long-term smoking abstinence rates. The nicotine replacement therapy is variable such as nicotine gum, inhaler, nasal sprays, transdermal patches, sublingual tablets, as well as the pharmacotherapy with varenicline, propion, and nortriptyline reliably increase the long-term smoking abstinence rates and significantly more effective than placebo. في عندنا multiple complications for COPD patients. They can have pneumothorax, cor pulmonale, or right-sided heart failure due to pulmonary arterial hypertension, with multiple exacerbations of COPD that needed hospitalization, non-invasive ventilation, or intubation, and respiratory failure. The respiratory failure could be hypoxic, but most probably will be hypercapnic. COPD comorbidities, it is an important slide. It influences the treatment of COPD, it influences the outcome of the COPD patient, and it influences the rate of exacerbation and frequent hospitalization in our patient. The COPD patients are at increased risk for cardiovascular disease. In fact, it is the leading cause of death in patients with COPD. They die most probably from acute coronary syndrome. They may have osteoporosis, they may have respiratory infections, anxiety and depression, diabetes, lung cancer, and bronchiectasis. These comorbid conditions may influence the mortality and hospitalization, as we said, and should be looked for routinely and treated appropriately. We have something called asthma COPD overlap syndrome, characterized by a persistent airflow limitation with several features usually associated with an asthma and several features associated with COPD. It is therefore identified in clinical practice by the features that it shares with both asthma and COPD. Thank you very much. If you have any question, do not hesitate to contact me either through your CR Mus'ab or directly on my email. I am more than ready to answer your question, guys. Best of luck.